Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. Subscribe at kevinmd.com/podcast. This episode of the podcast by Kevin MD is brought to you by Novartis Pharmaceuticals Corporation. Today, we welcome Seth Baum, a Columbia-trained preventive cardiologist, founder of Flourish Research, and chairman of the Family Heart Foundation. He has published more than 150 papers, led more than 150 clinical trials, and is a past president of the American Society of Preventive Cardiology. Today, Dr. Baum joins us to discuss the new American College of Cardiology, American Heart Association cholesterol guidelines and what they mean for your practice, and why LDL cholesterol goals just changed for the first time in 8 years. Dr. Baum was not compensated for his participation in today's episode. The opinions expressed are his alone and do not represent the opinions of Novartis Pharmaceuticals Corporation. Find out more at novartis.us/cardiovascular-disease. That's novartis.us/cardiovascular-disease. I know that's a mouthful, and a link will be in your show notes. Dr. Baum, thank you so much for joining us today.
Looking forward to this conversation.
All right. So let's briefly introduce yourself, then we'll jump right to the recently updated guidelines.
Sure. I actually, believe it or not, I started as an electrophysiologist and an interventional cardiologist. And in about 2000, I became a preventive cardiologist and clinical lipidologist, which I've done since then. You mentioned a couple of important things, the American Society for Preventive Cardiology, my involvement there. Also, the Family Heart Foundation, which is very, very important. I'm the chairman of the board of that organization, and that really focuses on familial hypercholesterolemia, Lp(a), and actually the broader issue of cholesterol, which is really our topic of conversation today. I've also, just a final thing, been involved in a good number of clinical trials, one of the founders of Flourish Research, and currently serve as a senior advisor to its board.
All right. So the big news, of course, in the world of preventive cardiology was the recent update in the cholesterol guidelines that were released in March. So before we talk about those updates itself, tell us about the events leading up to that update, just to give us a little bit of context and setting the stage.
Wow. So those events actually probably date back to 2013 guidelines, right? When there was a shift away from focusing on goals that had a negative impact on, we believe, on outcomes and management of cholesterol. It was somewhat improved in 2018 guidelines. Now in the 2026 guidelines, a very significant improvement, which I know we're going to discuss at length. I do want to say at the outset that although the guidelines are certainly an advance, getting back to where we should be and a little bit forward, they're not the final guidelines. There's much more work to be done. There's certain, in my view, flaws with the guidelines, many, many positive aspects, but hopefully we'll touch on all of this.
Now, as you sit back and reflect on the changes that were announced in March, tell us the changes that were most important to you, and what does that say about our thinking on cardiovascular risks and how that's changed since 2018?
Yeah. So I'd say that moving away from looking at LDL targets or LDL goals and looking at the management of cholesterol, LDL cholesterol specifically, just on the basis, frankly, of the introduction of a statin, right? Or a percent reduction in LDL. Moving away from that, now focusing back again on LDL, I think that's probably the most important aspect of the guidelines. There are many other things that relate to Lp(a) and LDL, frankly, that we'll talk about, but just getting back to LDL's bad, let's get it down, without any confusion. I think that's very, very important. The other, I think, an overarching theme is the recognition that we had gone the wrong direction, that we needed to, make a correction. And that's, I think, a very positive outcome of the guidelines, these multi-society dyslipidemia. And they're dyslipidemia guidelines. We always call them cholesterol. This year, we're calling them dyslipidemia. They impact triglycerides and other aspects of lipids and lipoproteins as well. Our main focus, though, obviously, is on cholesterol.
Now, for our friends who may not be versed in preventive cardiology and doesn't follow the minutiae of the guidelines, tell us a little bit about the course correction that you mentioned.
Yeah, you know, previously, when I say previously, within the last, let's say 10, 15 years or so, we had moved away from a focus on what LDL should be in a given risk population. So we always say we treat according to risk, right? The higher the risk, the more aggressively we treat, the greater the benefit and outcomes. So we treat according to risk. But what we had moved away from was saying, okay, we know that reducing LDL is beneficial. And we have multiple studies that have demonstrated this, right? We have the cholesterol treatment trialists, 20 plus studies. There's a very clear linear relationship to LDL reduction, reduction in cardiovascular events. For every about 40 milligrams you reduce somebody's LDL, you reduce their risk by about 20%, right? We've known that, and it goes all the way down close to zero. There's no, point where it goes away. But we had gone away from that. We had ignored what patients' LDLs were, and as a consequence, quite frankly, if you looked at people with acute coronary syndromes a year out, most of them were not on their lipid-lowering therapy and had LDLs that were, much higher than they should be. The course correction here, it stipulates with a new actually risk equation that we could talk about as well, but it stipulates exactly where that LDL should be below, okay? Not at that number, but below. It should be below 55 in the highest risk patients, 70 for, slightly less high risk, and 100 for others. So it does that. I'd say that's the big course correction and that we've made.
So it sounds like you said, more of a focus on target goals, more of the focus back on LDL cholesterol, and just kind of clarifying the goals to make them certainly reachable from both our standpoints, you as a preventive cardiologist, me as a primary care doctor.
Yeah, let me address that reachable aspect here. If we wanted to, we could reduce everyone across the board, everyone's cholesterol down into the 30s. We really could. Well, there are a few exceptions with severe homozygous familial hypercholesterolemia, but they're really very much the exception rather than the rule. We have the capacity to reduce LDL to levels that would dramatically reduce the incidence of cardiovascular events, dramatically. And one of the things we're always focusing on, and this is one of my, problems with the guidelines, is where we focus on like de-risking people. We focus on, well, who should we not treat? At this point in time, we know cardiovascular disease is on the rise, actually, right? Mortality from cardiovascular disease, which had been steadily going down, is now going back up. It's a very bad thing. It is not the time to say, okay, let's leave some people alone. That we should leave people alone and not treat them if there are safety issues with these drugs. But these drugs are really, really safe drugs by and large. And so it comes, in my view, it comes down to a price issue, a cost issue, that we, are concerned about the economic impact of over-treating. The problem is when you limit the number of people you're going to treat, you definitely put some people at risk who are going to have events. And I personally don't like that.
So we talk about why this is such a challenge because we know we can bring everyone's cholesterol down. We know that these medicines are safe. Talk more about some of the challenges that we face in medicine when it comes to reducing people's cholesterol and lowering their cardiovascular risk. What are some of the challenges and obstacles that we still face?
Yeah, so the challenges are manifold and multifactorial. There are multiple stakeholders involved. But if you look at the people and the institutions involved in lipid management, it has extended well beyond just the clinician and the patient. We now have policymakers who are very involved. We have the payers who are very involved. Believe it or not, the guidelines actually do influence the payers to some degree. They look at the guidelines and they can sometimes deny a medication on the basis of the guideline, unintended by the guideline writers, but it does happen. We have the experience of the PCSK9 inhibitors that were, launched about 10 years ago now, when the payers pushed back dramatically. It was the first time in my career as a cardiologist that I actually got denials for medications. I had never experienced that. I didn't know anything about this. I happened to be coming into the presidency of the American Society for Preventive Cardiology at that point, so I used my term, frankly, to try to understand and combat what was happening and get access to these medications for patients. But it was almost uniform, the denials.
Mm.
And then we had to learn about prior authorization. So the cardiologists and internists and other clinicians developed this, I don't want to say fear, but understanding and fear of the denial, the time suck it is in a practice. And it's created or it's added to clinical inertia in this space. So and then I should not ignore the fact that we've been so hyper focused on statins,
Mm.
and there's so much anti-statin sentiment out there, and we hear it. Anybody practicing medicine hears it from their patients. Oh my God, statin, my legs are going to fall off. This is going to happen. Terrible things, and we have to fight that when we know scientifically, based on hard evidence, randomized clinical trials based on Mendelian randomization studies, it doesn't matter how you get the LDL down. If you get it down safely, it's the same with the one drug or lifestyle. It's where you get it, right? How quickly you get
Yeah.
it down and where you get it. So if we could just establish that as gospel, which it is, we would help eliminate some of these problems.
So let's talk about the patient resistance to statins, or some patient resistance to statins, because I see this every day in my exam room. I'm sure that you do in your exam room. How do you address that with patients? How do you present a potential side effect of statins, which are largely safe drugs? How do you present those risks to patients?
Well, I first of all, I assess the patient's position with regard to statins. If you have somebody in the office who is a hardcore anti-statin individual, it's unlikely you're gonna, have great success. So I would attempt early on to say, look, we have a lot of clinical trial data. These are the safety data. I present it to them. And then if I see that I'm not really making much headway, I quickly go to another direction. There are other drugs that also reduce LDL cholesterol and are effective. We don't have to do statin. Let's go here. Let's do this other thing. So I do make that pivot. I never try. I never allow myself to engage in that battle with the patient where you're saying, no, 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 this is it, and I'm right, and you're wrong, because we tend to lose those battles, and we lose their confidence, which is another thing we have to contend with, is that there's a tremendous lack of confidence in us nowadays, unfortunately.
Just to be explicit about the safety data of statins, just give us some of the numbers in terms of potential side effects. We talk about elevation of liver enzymes. We talk about muscle aches. What are the actual numbers when it comes to
Yeah,
those potential side effects?
they're very clinically meaningful elevation in liver tests is extraordinarily rare. I actually don't, I can't give you it's very, very rare. And it may, it could vary a little bit from drug to drug, but it is very rare, certainly less than 1 in 1,000. Rhabdo also similarly, extraordinarily rare. When it comes to the sort of more subtle stuff, the myalgias, the weakness, the brain fog, those numbers can be much higher. It depends what you read. It can be in the 20% range.
Mhm.
But none of those issues is going to prevent you from utilizing a statin, because if you were to get one of the very rare and serious complications, you just have to be on top of this with your patient, explain what could potentially happen in unusual circumstances. We stop the drug, we treat the situation, and we, typically do well. I've never, frankly, seen a long-term problem from that. With regard to the other stuff, the more subtle stuff, you just stop the statin. You try another one, stop it, and then you move on to another class of drug.
So let's talk about those other classes of drugs. So if we have a patient for whatever reason cannot tolerate or doesn't desire a statin, what other options do we have in the exam room?
Well, we have the PCSK9 inhibitors for one. The monoclonal antibodies are phenomenal and reduce LDL 60%. Also can have an impact on Lp(a), depending upon the study, 20 to 30% reduction. They're not indicated for that, right? It's a side benefit. In some patients, we have ezetimibe, which is cholesterol absorption inhibitor. We have inclisiran, with small interfering RNA for PCSK9, which got a bump in the new guidelines in severe hypercholesterolemia. So, we have bempedoic acid. We have a lot of tools in our armamentarium, and we need to avail ourselves of those tools.
So, just to sum up this arc of our conversation, how should physicians think about LDL screening today? What did these guidelines change specifically about LDL screenings and reframe that particular lab value?
Yeah, so I'd like to go back to the basics here
Yeah.
when we talk about LDL and say unequivocally, LDL leads to vascular disease, strokes, heart attack, cardiovascular death, right? Unequivocally. We have multiple lines of evidence, and we know this. We have genetic evidence, we have clinical trial evidence. So we know this. We know that the higher the LDL, the greater the risk. We know that the lower the LDL, the lower the risk.
Mhm.
We know that getting LDL down quickly is better than taking your time doing it. And we also know from Mendelian randomization studies that those individuals who are gifted with a mutation, that's some mutation that diminishes LDL from in utero and beyond, they have about a 50% reduction in cardiovascular risk for every millimole reduction in LDL. That's for every 40 milligrams per deciliter, they get a 50% reduction, as opposed to what we know in clinical trials would give you a 20% reduction. So it's so much better, right? So we know all of this. So I think what the take-home message is, we need to look at LDL very differently. We cannot think of the LDL hypothesis. We have to eradicate that term. It's the LDL fact, the LDL truth. We have to approach it as our greatest opportunity to reduce the risk of heart attack, stroke, and cardiovascular death. We need to measure it frequently. We need to treat it accordingly. We need to get the LDL down as low as we can. At the bare minimum, follow the guidelines. Better to go even lower, quite frankly. And we need to have that open conversation with our patients so that they understand that all we're doing is trying to help them. So these are the things that I would take away with regard to LDL and the guidelines.
We're talking to Seth Baum, a preventive cardiologist, and we're talking about the new American College of Cardiology, American Heart Association cholesterol guidelines, what they mean for your practice, and why LDL cholesterol goals change for the first time in 8 years, and the impact that has on you. So, Seth, in your exam room, how have these new guidelines changed what you do with patients? I know that these guidelines suggest new tests to consider. There's a new calculator, perhaps. So tell us about how these guidelines have changed what you do.
Well, so I'm not a good representation of where change may occur. I've been operating outside the guidelines for decades, quite frankly. My goal has always been, for the last 20 years or so, get the LDL down incredibly low, be very aggressive, use combination therapy. I would say where for the most, for physicians who had been using the prior guidelines, the change here would be that they would look at their patients, they would use the prevent calculator instead of the pool cohort equation. They have an opportunity through this
So talk more
calculator.
about that. What is the prevent calculator?
Yeah, so it's a new risk calculator that is based on a much larger and more contemporary population, and so its accuracy or calibration is greater, is better than the pooled cohort equation that we had been using for a very long time. So that's now what we're supposed to use. You're supposed to risk stratify your patient, and then you look at the guidelines and you say, okay, this patient has such and such a risk. The recommendation is, get the LDL down lower than whatever. Again, in the highest risk patients, less than 55. So it's a good thing that we have this new equation. The problem is the equation tends to de-risk the population. And this was understood by the guideline writers. And so they lowered the limits of risk. So it's 3 to 5% for low risk, 5 to 10% for intermediate risk, over 10 instead of over 20 in the past for high risk patients, right? So it makes they try to accommodate for that diminished risk that's inherent in the calculator by reducing the risk categories to equilibrate. The problem is when that was studied in several centers, major centers, 3 out of 4, it didn't pan out. It still underestimated risk significantly. That's one of my fears about these guidelines. And I know I've strayed from your original question, but I think it's an important, straying. It's a risk because the last thing we want to do is underestimate risk and leave somebody untreated where you could be treated and potentially experience a cardiovascular event. Who are the people who are at greatest risk for being underestimated? Patients not currently on statin therapy. When we're thinking, should we put the patient on a lipid-lowering therapy? That patient is at higher risk of being underestimated. That's not who you want to underestimate. Men, we have a higher risk, at a younger age of cardiovascular disease. Women have very high risk, but men, blacks, people on antihypertensive therapy, and some diabetics. So we're putting at risk some of our higher risk patients. So I would caution people when they use these guidelines, use them to help guide you, but don't use them so explicitly that you restrict therapy in individuals who might be at enough risk and deserve treatment.
Now, from the perspective of the guideline writers, why did they choose the methodology that they did that, as you said, perhaps has a potential to underestimate risk?
So it's a more modern and much larger group that it was studied on. So it's more contemporaneous. And in that regard, it's definitely more appropriate. It needs some recalibration and they tried, but I think it was not adequate. And I think they'll come back and, ultimately fix it. And they're telling us also that, within a year, they're going to have an update. So that's a very good thing. Other things were omitted. The Vesalius study we could talk about, which was a primary prevention study, which demonstrated getting LDL down very, very low with PCSK9 inhibitor down to 45, reduced the risk of significantly reduced the risk of cardiovascular events. They will make an update in that as well. But back to the pooled cohort equation versus prevent. It's estimated that about 14 million Americans now won't be eligible for statins on the basis of the new risk calculator. And there's a potential for 100,000 cardiovascular events over 10 years that we don't need to have. Again, it's this balancing act of overtreating and undertreating. And my personal stance is I'd rather overtreat a population. Kind of if I can use an analogy, it reminds me of when I was in the cath lab years ago.
Yeah.
And when you had a patient with acute coronary syndrome, if you didn't get 10% normal caths, you were doing too few caths. It meant you were missing the real thing. You have to over study in order to be able to get the high risk population. Here you have to overtreat.
Talk to us about lipoprotein A. I think that the guidelines did make significant mention about that. So I know a lot of cardiologists have already been measuring that, but now it's been almost codified into these guidelines. So tell us about what the guidelines say about lipoprotein A.
So I'm happy to hear you say that a lot of cardiologists are measuring that, because that to me means you've spoken to a lot of people who are measuring it. The reality is that in the United States, only about 5% of the population has had Lp(a) studied, checked. So we've definitely underchecked. And so what is Lp(a)? Lp(a), or lipoprotein small a, is like a very small LDL particle with a little tail on it called ApoA, and it is a triple threat. It increases the risk of the development of atherosclerosis. It increases the likelihood of thrombosis, and it increases inflammation. The phospholipids carried on it are abundant. and they become heavily oxidized. It's a highly inflamed particle. So it's doing everything wrong with regard to our vasculature. And about 20% of the population has high Lp(a). It's a genetically driven lipoprotein. And about 20% is over 125, which conveys about a 40% additional risk of a cardiovascular event. What the guidelines did was great, okay? We caught up with our friends in Europe and in Canada by saying, let's do universal screening. Everybody needs to know his or her Lp(a). It's important. Once you know Lp(a), you can and should do things. You should reduce cardiovascular risk. That's in our guideline because it's helpful. You should cascade screen because it's genetic. So you need to check first degree relatives, then move out to other relatives as you keep finding individuals with elevated Lp(a). You should know that there is a risk inherent in Lp(a). That's, as I said, 40% additional cardiovascular risk at an Lp(a) of 125. At about 200 to 250, it's about a twofold increased risk. And about 430, 450, it's about fourfold increased risk, making it somewhat, perhaps as almost as bad as familial hypercholesterolemia. So we know that the level of the Lp(a), just like with LDL, the level of the Lp(a) will dictate the risk. Since it's genetic, it's here from birth and before in utero, the same problems we have with genetic LDL disorders. So it also, the guidelines also did state, and I was very happy with this because everybody says, oh, there are no therapies available for Lp(a). There is actually apheresis, which is approved for Lp(a). So we already have that, and we will have therapeutics, for, God willing, in the not too distant future for Lp(a). So, one other thing that I think we should mention is that PCSK9 inhibitor monoclonal antibodies were sort of upgraded so that in elevated Lp(a), when there's additional LDL reduction required, it's recommended to institute a PCSK9 inhibitor because there is that 20 to 30% potential reduction, sometimes more, sometimes less in Lp(a). But in addition to that, they're very effective LDL reducing drugs, and we do want to limit our other cardiovascular risk factors. And from a population attributable risk standpoint, LDL is the most important one.
So a close cousin to lipoprotein A is apolipoprotein B. So comment on apolipoprotein B and its place in cardiovascular screening.
Okay, so ApoB, or apolipoprotein B, there are two forms of this. There's ApoB 100 and ApoB 48. In the liver, when we make VLDL particles, which are the precursors for IDL, intermediate density lipoprotein particles, which are the precursors for LDL, we have one ApoB 100 protein on the surface of the particle. These are very large structural proteins, and they also a piece of them will bind to the LDL receptor. So they're very, very important. But it's a one-to-one relationship. So it's VLDL, IDL, LDL. Those are all atherogenic lipoprotein particles. They cause vascular disease. Lp(a) has one ApoB 100 on its surface. One-to-one relationship. Causes atherosclerosis as a lipoprotein particle. Chylomicrons made in the gut have ApoB 48. We'll leave them aside now because they're not considered heavily to cause vascular disease. It's certainly not in their large state. So if you think about it, every single atherogenic lipoprotein particle has one ApoB 100 on it. And if we count ApoB 100, we can know very, very well what cardiovascular risk is attributed to our lipoprotein particles. Okay? So that's why it's important to measure ApoB. It's a more accurate way to assess cardiovascular risk from a lipid and lipoprotein standpoint than by looking at LDL. It's more accurate. The other thing is when we treat dyslipidemias with medications, we tend to cause a disconnect where we reduce LDL more than we reduce ApoB. So and this happens predominantly, not exclusively, predominantly when triglycerides are high or HDL is low, in the setting of some renal disorders, diabetes. It happens in those settings. What happens then? So you get the LDL down, and now it's down to 50, and you're thrilled. You go, "Oh my God, it's great! I made it. I've reduced the risk as best as I can." The reality might be that ApoB didn't fall as much as LDL and is still too high for that patient. So by checking ApoB, you can more aggressively treat the LDL and drive the ApoB down to a lower level and be more protective. Now, this does happen across the board, even in a condition like familial hypercholesterolemia, which is really an LDL disorder, right? It's not a triglyceride and HDL disorder, but yet it does happen there too, where we get the disconnect. So my personal feeling is always check an ApoB in your patients you're treating for, with a lipid disorder and you're treating to reduce their cardiovascular risk.
And in contrast to lipoprotein A, how sensitive is apolipoprotein B to statin therapy and some of the therapies that we talked about today?
So statin therapy is not going to reduce Lp(a).
Yeah.
It will reduce ApoB. All of our lipid-lowering drugs will reduce ApoB. Unfortunately, they reduce ApoB less than they reduce LDL.
Mm-hmm.
And as a consequence, you can get that disconnect. With regard to Lp(a), we have to say that we currently don't have any on the market, any effective drugs to reduce Lp(a). PCSK9 inhibitors, again, some people get a little benefit. It's never been, looked at carefully enough to determine what that would mean for patient outcomes. But it's certainly a side benefit of the drug. But there are no drugs that we have available for Lp(a). We have a slew of drugs available for LDL.
Mm-hmm.
Again, ApoB is the protein that you're going to consider that is on every one of our atherogenic lipoprotein particles in a one-to-one relationship. So that's Lp(a), VLDL, IDL, LDL. So that's why it's kind of in its own class, and we need to look at it more carefully and test it.
The other part of our guideline that I want to touch upon is coronary artery calcium
Mm.
scoring. So, what do the guidelines say about that particular test? Or maybe just start by introducing what that test is for those who aren't familiar with it, and then what the guidelines say about it.
Yeah, so there are different ways to image the coronary arteries. Coronary artery calcification scoring is a non-contrast CT scan that analyzes and basically counts how much calcium one has in your coronary arteries. On the basis of a ton of data accumulated over the decades, we can now say what somebody's risk is for corrected for age and sex, how much risk of having a future cardiovascular event. And the presence of coronary calcium dramatically increases the risk of cardiovascular events. What the guideline has done, which is, I think, a beautiful move, is said that if you have a calcium score of greater than 300, then you should be treated as though you're in the highest risk category
Mhm.
of somebody who's already had a heart attack. You are very high risk. So your LDL should be under 55. It's a great way. We used to use it as sort of a risk enhancer. Your calcium score is high. Oh, yeah, your risk is a little higher. We should reduce your LDL. Now we're saying, oh, no, no, no. It's a dramatic risk enhancer. You basically have a tremendous risk of having an event as though you've already had two heart attacks, let's say.
Yeah.
So I love that. The other imaging technique is coronary CT angiography, which is typically reserved, that's with contrast, where we actually see the wall of the vessel. We can even analyze in some circumstances how much inflammation there is, what kind of plaque, is it soft plaque, is it vulnerable? It's a tremendous test, but it's typically reserved for patients with symptoms. Again, I sort of practice outside the guidelines, and so I've been using it to understand risk even better with the appropriate shared decision making conversation with patients.
Now, from a primary care standpoint, who are the patients I should be looking for to order a coronary artery calcium score?
So yeah, I would say if you have a suspicion of a high risk circumstance in an untreated patient, then that's a great place to think about using a coronary calcium score. So you think the patient should be on therapy? Patient's going, no, 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 I don't want to be on therapy. You do a calcium score, and you say, look, you have coronary disease. This is coronary disease, by the way.
Mhm.
I think it's also important when you do order it and when you do get the test back that you say to the patient, look, the calcium is a late finding in coronary disease. So first you get a soft plaque, and then as that plaque heals, calcification is laid down. Cells in the plaque actually transform into basically bone cells. They lay down calcium and to heal the plaque. So a lot of time has gone by. So it helps them understand the nature of the disease and the risk inherent in it. So those are individuals you should get it on. You shouldn't, in my view, get it on individuals who have established coronary disease and you're tracking them over time. It's really to make the decision early on to treat, not to treat, how aggressively to treat now because we have that greater than 300. I would add if also greater than the 75th percentile for age and gender match controls. And yeah, that's those are really the patients I would consider using them on. There's a little caveat. Since it takes time to develop calcium, you can sometimes miss people. So in younger people and women, they can sometimes have soft plaque and not calcific plaque. So I wouldn't look at it as, oh, you have a calcium score of 0, therefore you're out of the woods. You have to keep in mind that, and I have seen these people, and that where calcium score of 0 and a 90% soft plaque in the LAD. Okay.
Mhm.
So there is that caveat. It's not common, but it happens often enough.
We're talking to Seth Baum, a preventive cardiologist, and we're talking about the new cholesterol guidelines from the American College of Cardiology and American Heart Association. This episode is sponsored by Novartis Pharmaceuticals Corporation. Find out more at novartis.us/cardiovascular-disease. I know that's a handful, but that link will be in the show notes. Seth,
Yes.
couple questions to end off. First, what do we have to look forward to when it comes to cholesterol screening and preventive cardiology? What's on the horizon?
What's on the horizon? That's a yeah. So you mentioned Horizon. Horizon's a clinical trial that's looking at Lp(a), the first drug that hopefully will get a great result this year, and we'll have a drug available for Lp(a). So I'd lead with that since you used the Horizon word. So hopefully people will pay attention to Lp(a). Hopefully people will start screening everyone, and that doesn't mean just one test in a lifetime because it's genetic. There are times where you want to get a follow-up test, such as after menopause when Lp(a) goes up quite significantly. So I would say for Lp(a), we're leading with. With regard to LDL, my hope is that we clinicians embrace LDL as a genuine risk factor, not hypothetical, that we understand the science and the medicine, that getting LDL lower, doing it faster is better, and the longer it stays lower, the better. That is just it's one of the few things in medicine, quite frankly, that I would say is factual, is that. So I would hope that happens. I'm looking forward to updated guidelines that are broader, that include more people in LDL reduction. I'm looking forward to hopefully the guidelines helping push for quality measures that address not just statin use, but checking LDL and reducing LDL. I'd love to see the quality measures in place that do that, just like we have for hypertension and diabetes, right? We don't say in our quality measures, did you start one medicine on your hypertensive patient, or did you give them a medicine for diabetes? No, we check the hemoglobin A1C, we check the blood pressure. Here we have to check the LDL, and we have to manage it. So those are some of the things that I'm excited about and hopeful that we can turn this around, that people will no longer be, in a sense, like complacent or bored of LDL because they've heard about it so much that they just embrace it. Let's tackle this. We have the capability, we have the drugs. Let's just solve this problem and dramatically, I mean dramatically reduce cardiovascular events, strokes, heart attacks, and cardiovascular death in the United States.
Any tips you have for physicians to communicate these new guidelines with patients? Patients are reading about these guidelines on mainstream media. They are coming to our offices with a lot of questions. What kind of tips do you have for physicians to best communicate these new guidelines to our patients?
It's an interesting question, and this may sound silly or basic, but I have always found that going very much back to the basics of biology and physiology at the start of the conversation helps when discussing cholesterol. And I say this because there's a ton of misinformation about cholesterol. You get the patient who goes, well, my brain has a ton of cholesterol and I'm going to, decrease cholesterol in my body and that's not good. My steroidogenic tissues, we need LDL. So I go back to the basics and I start with a very simple statement about the fact that water and fat don't mix. I go, water and fat don't mix. If you make salad dressing, you shake up the salad dressing, the oil and water separate, you get these little bubbles. The body can't have that. We wouldn't survive. So very intelligently, we have these lipoprotein particles that transport cholesterol around the body. LDL is one of those. And LDL, we know in the body, does nothing other than go back to the liver to basically dump the cholesterol. LDL does not cross the blood-brain barrier. The brain does not use LDL cholesterol. Every cell in the body makes its own cholesterol. Every single cell. Well, all of our steroidogenic tissues are making their own cholesterol. They're not using LDL. That has been proved, right? So you start with that and you go, well, wait a second. If it's bad, why should we keep it around? Well, look at a child, a newborn whose LDL is somewhere in the 30, 40 range. All they're doing is making their brain, right? That's their goal for the first several years, is to create their brain. If the brain required cholesterol, their cholesterol will be 500. So let's get rid of this cholesterol. We have the tools to do it. We have the drugs, and then you go into the studies, the genetics, the Mendelian randomization studies, and you make the case for LDL reduction. I spend that kind of time. It may take 5 minutes. I'll give you that. But I really think that it engenders trust and confidence, and it eliminates a million other conversations when one drug, there's side effects. You can find, we'll try another drug, right? It eliminates those conversations, makes your life so much easier down the road, and many, many more patients embrace lipid-lowering therapy.
And my final question, Seth, your take-home messages that you want to leave with the Kevin MD audience.
Please, please, please take LDL seriously. We have the ability to reduce LDL and by so doing, reduce stroke, heart attack, and cardiovascular death in the United States. Let's do it. And the second part of this is Lp(a). Check Lp(a) in all of your patients. It is so important. It's now in our guidelines, but you can do things about it. And soon we will have drugs to deal with it. So check Lp(a), take it seriously. And a final one, I'm going to put in a plug for the Family Heart Foundation, of which I am the chairman of the board. There are tremendous resources at the Family Heart Foundation to help you and your patients navigate the cholesterol and the Lp(a) world, and help even in accessing medications when appropriate for your patients. So please go to the Family Heart Foundation website and use some of the many, many materials that we have. We also, by the way, have a free cholesterol and Lp(a) screening system in place. So there are many, many tools and assets on the Family Heart Foundation website that I'd love everybody to look at.
We've been talking to Seth Baum, a preventive cardiologist. This is a sponsored episode brought to you by Novartis Pharmaceuticals Corporation. Find out more at novartis.us/cardiovascular-disease. The link will be in the show notes. Seth, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thank you. Thanks for having me.